This episode is sponsored by Dr. Chrono by EverHealth, the #1 mobile all-in-one EHR. Built specifically for medical practices, Dr. Chrono includes an integrated feature that powers a seamless payments acceptance experience. Dr. Chrono Payments offers multiple ways for patients to pay as well as insurance credit card processing. As a Dr. Chrono customer, you can easily activate our fully integrated payment solution that will streamline your cash flow and help you get paid anytime from anywhere. Deliver the best patient experience with a fast and easy way to collect payments. Visit drchrono.com/payments. That's drchrono.com/payments to learn more about Dr. Chrono today. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story Podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Maryal Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct primary care is the way out of what has become factory medicine, where you just have patients coming in like widgets and you're supposed to do this and this and this to them, and there's no creativity, and it has to go faster, faster, faster. And we didn't go into medicine for that. Direct primary care is how we get to do it our way. We see the patient, we have a relationship with the patient, we get to really know them, know what they need, know what is going to help them to heal, and we get to do it the way that we know is right. If you join DPC, it's your chance to get out of the rat race, of the crazy soul-crushing factory medicine situation, and be able to be creative, be able to really, really connect with your patients, and be able to be excited about going to work every single day. I'm Dr. Angela Bymaster from Healing Grove, and this is my DPC story.
Dr. Angela Bymaster is a family medicine physician at Healing Grove Health Center. She went to medical school at the University of Iowa Carver College of Medicine and did her residency at the Stanford O'Connor Family Medicine Residency Program. She worked for the Santa Clara County Homeless Program for 6 years and a small low-income community clinic for 5 years before founding Healing Grove with a few partners. She is passionate about upstream primary care, addiction treatment, childhood trauma, and the intersections of health in the body, the soul, and the community. She lives with her husband and kids in a tight-knit, low-income Latino community in central San Jose. She also loves Jesus, playing volleyball, eating homemade Mexican food at her neighbors' houses, and reading mystery stories. Welcome to the podcast, Dr. Bymaster.
Thank you. Great to be here.
It's always fun to talk with another Californian. I love that not only are you Californian, but you're a Northern Californian, and you have 4 locations to Healing Grove Health Centers. So super excited to hear your story today. I wanted to say also that I loved that just preparing for this interview, learning that you went to what's now in the Stanford Health System, the San Jose O'Connor program for residency. I shout out to Dr. Rye's wife and all of her amazing chai that he would bring to clinic. Yeah, love rotating.
I partook of the chai.
Amazing. So especially if you haven't and you're a medical student who's interested in family medicine, rotate at O'Connor, just throwing that out there. You have such an interesting story, not only because of you being a DPC doctor and now having 4 locations, but the way that your model is different is that your model is a Robin Hood model. So for those people who are like, wait a minute, I've been wanting to hear about Robin Hood, nonprofits, and DPC, all this stuff, tune in to what Dr. Bymaster is going to be talking about. But I want to start off first with your journey into DPC. You were for 11 years in 2 different types of clinics after residency. So I wanted to ask, just stepping back into that moment where you were like, I am now deciding what I'm going to do after residency. What did you envision? And did that envisionment lead you to choosing these two clinics prior to opening Healing Grove?
Yeah, initially I was in a spot where I was building my family in a little bit unusual way. I had two foster kids who were teenagers who were very challenging, and I had just finished residency. I was really involved in my neighborhood, which I like intentionally moved into one of the lowest income neighborhoods in San Jose. And so it's just a very unusual path, the whole thing. But I really wanted to focus a lot on building our community and just being a part of that. And so I wanted to work part-time. And so I came out of residency just looking for like, what's a part-time job? But also I was really, really enamored with serving the poor. And so I initially went with the county homeless program and worked there as an FQHC for Santa Clara County's Valley Homeless Healthcare Program for 6 years, and had a great time there, learned a ton. But it was like, yeah, there was pieces of it that were not quite satisfying to me as well. After that, I went to a FQHC that was in the neighborhood where I lived, in that low-income neighborhood, and also learned a lot there. And again, was able to work part-time. It was like, I think I didn't want a whole lot of responsibility. I just wanted to clock in and clock out and do my job and like be able to be home with my family. And so I think for those years when I was really raising my kids, it was convenient to do that type of medicine. But then it really got to the point where I just felt like the quality of care that I was able to do in the FQHC where I was just not to the level that I wanted to do.
When I hear a lot of medical students and residents talk about like FQHC is so in alignment with me being able to service the people who might not have the funding to have these amazing concierge plans that we have in California. And I say that facetiously because $40,000 is still billing insurance if you're with a concierge doctor. But you're speaking, having over a decade of experience in the model of you're an FQHC, you get funding differently than a clinic that's a non-FQHC. People expect that people who are working in FQHCs are very more patient-centered and patient-focused and patient-driven. You mentioned there were pieces that were not satisfying in particular. So I want to ask about, as you found it served your needs at the time, which I totally get, because as a mom of little kids, it's like there are days when I'm like, okay, now I have to build a web page about this. I can easily see how the mom and you talking just now was like, I just need something to fill the bill right now. But as you continued, you mentioned this idea that there were pieces that were not satisfying. So can you go into more detail about those pieces and how they grated on your soul to eventually help you decide to leave that system to open Healing Grove?
Yes. Let's start with the first one. The first one was county. And it was very government. It was very top down. Like I would see major needs, obvious low hanging fruit. My patients need this. I would talk to people. Nothing would happen. It was like, it's like an aircraft carrier. You cannot turn that thing around. It's going in its direction and that's where it's going to go. And you just have no say. And I'm like fundamentally I'm a very creative person. I'm not a systems person. I like to solve problems. I like to see solutions. I just flight of ideas all the time. And so that was frustrating because we were always implementing some county program that did not matter. I mean, a good example is the PHQ-9s. They like really rolled that one out. And I'm like, okay, all my patients are homeless and many of them are like severe mental illness. Like I know what they need. A lot of them need a place to live. They need psychiatrists. They need to take their meds. They need to stop using meth and fentanyl. And there's a lot of things they need, but PHQ-9 is not what they need. Like 100%, we all know it's not the right tool for them. But they would roll it out and we had to do it. And so that over and over and over, I was just like, okay, there is a huge disconnect between the people making the decisions about what we're doing, which always went back to funding, right? always was like somebody, Medi-Cal or Medicare, or somebody wanted to reimburse people a little more if they did this measure, if they told people to quit smoking, if they, whatever. But my patients, very often what they needed was something totally different from what was being rolled out. And I didn't like being in that spot where I was having to do something that my patients didn't need in lieu of not being able to give them what they did need. And some people can live in those situations because they know change happens slowly. And I have a really good friend who like stayed in that system, did a great job, slowly trying to change the system. But that was just not me. I was just frustrated every day. So next FQHC was one of those nurse practitioner controlled FQHCs. The was a nurse practitioner. They just hired so many NPs, and it became really clear that it was like a nurse practitioner training school. So they would stay there for a couple of years, and then they would go and get a real job at a place that paid well. And so I suddenly realized, oh, my whole job in life here, because their mission wasn't for the patients, it was to train NPs. And so we were like an NP residency or something. And a lot of the NPs who came didn't have any experience as nurses. They had just gone straight through some kind of a NP mill school. And the quality of care was very poor. I had often, like every day, people didn't know the difference between otitis externa and otitis media. People didn't know, people were missing appendicitis. And I just was terrified. I felt like I had to be there every minute of every day, even though I was working part-time. Because anytime I wasn't there, crazy stuff was going down, and we had holes in the floor, and the fax machine didn't work, and just everything was just like, I was like, man, we had so many temperature excursions on our vaccines, and we just never could give vaccines because we were always in some kind of excursion land with VFC, and it was just an absolute train wreck. And I was like, I don't want to have my name attached to this place. Like, this is really poor care. And it's clear to me that it's not about the patients. Because again, I would say, hey, you know what we need at this clinic? Like I would identify, oh, there's a lot of like relationship problems with the parents, and there is no like marriage counseling for them. So like, let's find a way to get the marriage counseling, because I think they're great people and they can work this out, but they need someone to help them. But that wasn't something that the FQHC would reimburse for. So that was not a possibility. And so once again, what they needed and what they got were two very different things. And then we would have these quality improvement meetings where there's like retired docs who were like overseeing us, the medical directors who were like, they were like some subspecialists. They would like go over fit tests and mammograms and stuff they didn't actually know anything about. And then they would try to lecture us on what they are and why we should do them. And I realized one day in my entire population, like if I had not done a single mammogram over the past year, I would not have missed any cases of breast cancer, because I had 2 cases of breast cancer that year. I had a very high pediatric population. I had 2 cases of breast cancer. One lady was 86 and one lady was 32. And so they were not in the screening age, and everyone else was a false positive after they looked into it. And so I realized, oh, wow, we're spending all of our time on this when we have so much mental health issues, so much relationship problems, so much obesity, so much other things that are going on, domestic violence, and we're not addressing that at all. And so I was just like, I'm wasting my time. I'm not healing anybody. People weren't getting better. I was just so tired of it. I'm like, why am I even here?
Stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com or check out the link in the show notes. So let me ask you there, because you stayed for 6 years at one clinic, 5 years at the second, and then at some point you decided to heal yourself and open up Healing Grove. So what was it that was like, this is the end of my 5 years. Peace out, man. I'm going to open my own clinic. What happened that drove you to leave?
I think it was a series of things. Just one of my really good NPs left. So she was an ICU nurse before she became an NP, and she was amazing. And then she left and got a job at a high paying clinic. And that's when it sort of dawned on me that like, oh, this is what this is. This is a stepping stone for them so they can have a career. And then I had given a kind of harsh review for another NP who was very weak clinically. And the medical director shared my review with that person against my wishes. And that created a really uncomfortable situation in clinic. And I was just trying to save, like, I felt like it was a patient safety issue and that the medical director needed to know. But then he just decided to share it with the NP, which was really not helpful, and say who gave him that review and everything. And so there was just so many unprofessional things like that I was like, it's not fun to be here anymore. There were a couple of patient encounters that were very unsatisfying that I just felt like not handled well. The front desk kept turning over, and we get a new front desk person. I would hear them saying, "Oh, yeah, we're really busy today. We don't have any room. Can you just go to the urgent care?" When I knew we had plenty of room, we had lots of openings on the schedule, and I was just sitting there bored. And sometimes I would just think, why did I even put my clothes on this morning? I should be wearing my pajamas all day. I'm not seeing that many patients. This is a waste of everything. It's a waste of the government money. It's a waste of my skills and training. Like, I want to be somewhere that matters, that does something useful. And then there was here's the mystical part. A prophetess, it's a woman from Honduras, came to visit her relatives. We live in a Spanish-speaking neighborhood here in San Jose. And she said, "Oh, I have a word for you." And so we had her over for dinner, and she said, "You're going to start a Christian clinic in this neighborhood. It's going to be called Hojas de Sanidad. And it's from Ezekiel 47 and Revelation 22. And it was this big prophecy." And so we said, "Okay, well, guess it's time."
I think that's so beautiful. My aunt in the Philippines was a healer, and there are some crazy stories that I've heard, but how amazing and beautiful is it that a person from a completely different country who experiences healthcare delivery in a very different way is seeing in you I'm sure she knew you were a doctor, fine, but it's like is sealing to the point that you probably hadn't shared with her all of the stuff that had been going on for the past 11 years. And yet she was able to say, I can totally see this. I think that the mysticism that you talk about, I went to a high school where we read magical realism stories up the wazoo, and I don't think that they're always magical and unrealistic. And so I think that is very beautiful, that's what was one part of your story. So let me ask you there, having this planted in your head that oh my God, opening a clinic, had you thought about it prior to her saying as such?
Sort of. So my dad is a doctor in Oregon, Southern Oregon, small town. And that's where I grew up. And so I grew up seeing his life and being a kid of a doctor in a small town. And you can't go to the grocery store without people coming up and telling them about your hemorrhoids. And it's just all everywhere. And he would take me on rounds because there's literally nothing to do in this town. So I'm 5 years old. I'm going to the hospital on rounds with him, and he's showing me pitting edema and all kinds of stuff. And so I'd sit there and listen to him dictate, and we would just sort of hang out. I'd go to all the nursing homes with him. So I knew what it was like. And I tried so hard to not do that because it was just consuming. It was night and day. And I was like, I'd like to have a little more of a life than that. And then it sort of just came for me because as I realized, as I was doing my FQ work and my part-time stuff, it was nice. And I think it was necessary at the time because my kids had some pretty special needs and I needed to like just have a lot of time for them. But then once now I have like 6 kids, depending on how you count them. And so I'm on the last two now. And those two are more able to roll with some punches. And so now it's working out for me to be a little bit busier. But I also think DPC is less all-consuming than the old fee-for-service. I mean, he was born in 1950 and he did his own ICU care. He delivered babies. He was like the whole thing. And I don't do all that. And so I just think that it's not as bad, but I think I was avoiding it because I knew how it could be. So it was in the back of my head, but I was like, oh, that's what I'm not going to do. And
I totally get that. And I'm sure other listeners who may have physicians as parents who were full scope family doctors or are full scope family doctors could easily see your thought process before opening Healing Grove. So let me ask you there, at that point, had you already been exposed to direct primary care as a model, or was that something that you discovered on your journey to opening up Healing Grove?
I had read about it. And every time I saw something about DPC, I would read the article because I was fascinated with it because it reminded me of the early days of my dad's clinic. And so because I got a front row seat to his clinic, he started out, it was him and a nurse and that's it. And he would tell me about the days before insurance really took over and how it was like, if someone came in and they had like an injured arm, he would say, well, an x-ray costs this much. Do you want to get it or not? And I loved that. I was like, that's amazing to just say like, you could just put a splint on it and just assume it's broken, or we could get the x-ray, but like, let's talk about what things actually cost instead of just demanding everything because it exists.
Wow. So yeah, it's so interesting to think that a doctor would ever say, "Hey, this is the cost you want it or not," because we have, for the most part, all grown up in. I mean, that doesn't encompass everyone, but for a majority of the listeners, just knowing the demographics that are behind the podcast listenership, people have not had that experience for most of the listeners. So it's pretty incredible to think that you saw that. So let me ask you here, with you doing so much work for the homeless population, for people who financially are not going to be at the top of the food chain financially, when you were thinking, okay, maybe I'm inspired by DPC, how do I go forward? How did you then transition to opening Healing Grove from this, could I possibly, to opening and physically having patients?
So a lot of this actually was my husband. My husband's amazing and he does a lot of the business side. So throughout, after we got our prophecy in November 2018, we just started reading everything we could, learning everything we could. We reached out to some of the DPC people online and got some recommendations for lawyers and just kind of started talking to lawyers. And throughout 2019, we were setting the groundwork and trying to fundraise and given that we're trying to do a Christian clinic, so faith-based, we also were talking to churches and saying like, hey, is this something you guys would support? And so we were just doing all of that. And it was clear that it was meant to be because we were, as we just we didn't know anything and we didn't have what it took and we didn't have enough money and we didn't like, it wasn't something that we were prepared for. And it just happened. And even throughout 2019, we had this sense that like, God was just saying like, faster, 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 like, hurry up, don't waste your time, don't dawdle. And we were like, it's 2019, like what could possibly be about to happen? And we just, what's the big rush? And then I put in my last day of work at my FQ for March 12th, 2020. And I can't remember the exact day. I think it was March 13th, 2020 was shelter in place, Santa Clara County. We were the first county to shut down. And all of a sudden we knew that's why.
It's just so crazy how things play out. It's so uncanny. So when you guys had already set this foundation, did you open day one with staff, or did you just have yourself and your husband and you would just figure it out as you went?
Yeah, we knew who we needed on board because again, we lived in this poor neighborhood. We moved here in 2006 when it came out for residency, and we've lived in the same neighborhood this whole time. It's the lowest income census tract in Santa Clara County, and our kids are at the local elementary school, and we're just a part of the community. And we knew there were two leaders who we really wanted on our team. So we actually hired them before we hired ourselves. And they were very low income themselves and Spanish speaking. And so we didn't get a paycheck for 9 months, my husband and I. We were totally living off of savings. And when we had a kid in college, and it was really a leap of faith for sure. We didn't have the place was under construction. We signed a lease. We were under construction. And so I would just had quit my job thinking, oh, I'll just for a month or two while they're finishing the construction, I'll, do my Quest contracts and all my stuff you got to do. And then we'll be ready to go. But then it was the day after I quit my other job, we were in shelter in place. All the FQs shut down. They locked their doors. No, there was nothing. And my people can't work from home. They just couldn't do anything. They didn't have savings. They didn't have space for extra food. The food bank shut down. It was a disaster. And everyone had our cell phone number because we're in the community and we're like, my kids are friends with their kids. And so all of a sudden the phones just started ringing and people are having fevers and coughs and they don't know what to do. And so I just started meeting people in the parking lot. And then our staff, we had a lady named Maria and a lady named Lourdes. And those two were just awesome. And so we just said, Maria, what should we do? And Maria got everyone together in the community and just said, what are your needs? And she had all these madres who were trained for years. She had the kind of a leadership group, and they all called 10 more madres. And pretty soon we just knew what all the needs were in the community. And we also knew who was able in the community to meet the needs. And so it became the first year, that's a whole other, it's you could write a book about it. It was crazy. We had people cooking a bathtub sized vats of chicken soup and delivering it to all the people with COVID. And there was this lab in Redwood City that donated $1 million of COVID tests for us. And we were just stamping out disease like crazy. And it was all parking lots, home visits, and people would refuse to go to the hospital. So we were making stuff up. I was like, what do I got? I got methylprednisolone. I got ceftriaxone. I'm just trying to figure out what I can give people to keep them alive. And it was nuts, but it was great.
I just think about how your experience was in the first 11 years prior to opening, even in a parking lot, but just how quickly I'm sure your soul just got years back just by that first year of practice, which is amazing and beautiful also. So let me ask you there, because you had these two amazing community leaders who were also organizers and who knew how to help get the needs identified, and then you had patients coming. How did you set up your practice so that you could have people not only coming, but people also paying for services to help you, buy the medicine that you needed, do things that you needed that were not unfortunately free?
So yeah, this is not a typical, this just doesn't apply to anybody, I don't think, because it was COVID and everybody was trying to figure out ways to help. And we had set up our network of churches, right? So a church just gave us $40,000 and said, do whatever you need to do with this money. And it was amazing that we needed that so badly. So I bought COVID test kits from Quest. I paid for the tests. We paid a couple of people's rent. We paid it was all just putting out fires when they came. We used that money up, and then the next money would come in. And so we got the city of San Jose and the county of Santa Clara couldn't figure out how to get money to the undocumented people because they just didn't have a place where they gathered. And so they found out that we had a really good connection to that community. And so they funneled $6 million through us to do rent relief because none of those people qualified for any of the federal rent relief or any of that, the stimulus money. And then the food bank was closed because they didn't have volunteers. And so we wrote a grant with the city of San Jose to pay people who were out of work because of COVID, who were really poor, to run the food bank. And then the church that we attend is like the biggest food bank distributor in the county. And so they had a huge warehouse. And so we just like made it all happen. And so then all of our basically patients and community members were at the food bank every day processing the food. And then we also had shipments come to our clinic. So we became a food bank distributor for like a hot second, just so that people could have food. And so we had hundreds of people coming every day just to get food. And then we just set up, like, again, with that Redwood City company, they were trying to develop a COVID test that was like saliva based. And so we became a clinical trial site for them. And just so that we could get, because for the gold standard, they needed to do the PCR. And so we're like, we'll do whatever it takes to get some PCR. And so then we ended up being the only site in the county that didn't require an email address, didn't require an appointment. We did it in Spanish. You could just show up at certain times. And so it was like Monday, Wednesday, Friday, 3 to 6. Anybody can come and we'll COVID test you. And so pretty soon we had lines going all the way down the block, and we would do 350 tests in 3 hours. And we had a ton of volunteers because we figured out, oh, those 20 to 30-year-olds don't get that sick. So, and they're all they're home from college. And so we just said, if you want to take the risk, like, come and volunteer with us. And so we had this great group of young people who just volunteered all those hours, and they were awesome. And a couple of them are in medical school right now. And I was like, I'll write you the best letter of recommendation. So anyway, it was a very special year. And it was one of those, we just called it a miracle. Like, we never knew where the money was going to come from. And then it just kept showing up. And by the end of the year, we had a retired nurse who spoke Spanish who would call everybody. We had a whole spreadsheet of all the people who we'd been testing. And she just called them every day to see how they're doing. And a lot of them didn't know about ibuprofen and Tylenol, and just like, get your fever down with this and drink lots of water, and praying for them and just encouraging them. And she got a hold of almost everybody. And we are not aware of, we did 10,000 tests by the end of the year. We had 2,500 positives. We never went below a 25% positivity rate because we were in that community. And we're not aware of any deaths. So it's amazing.
Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad. That's incredible. I want to say that recently, at the time of this interview, the House bill that was bipartisan by Dr. Kim Schreier and Dan Crenshaw saying, hey, could we explore if Medicaid could pay for DPC membership rather than coding to be paid for DPC membership? That is something that I encourage everybody to read about. It's literally less than 3 pages. It is not like, even in a busy world, you can definitely make time to read this. But the reason I bring that up is because when Kim Schreier was learning about DPC, Dr. Garrison Bliss said that in my practice, like, he was still practicing at the time, when I was available to my patients, not a single patient died during COVID in my practice. And so I think that I am so grateful that you shared what happened and the details that you shared, because that is what people need to hear who are making laws in this country, that, oh my gosh, the access that a county couldn't even figure out, you just like delivered left and right with yourself, the volunteers that you had in your whole community, the churches, everybody was pulling together to help each other. So that is incredible. Now, let me ask you there, fast forwarding past crisis mode during the pandemic, when you guys had reached a time where it was, okay, now we can really start taking care of people's primary care needs. COVID is not so demanding on our time or our resources. How did Healing Grove change so that you could have members and you could have patients who were not necessarily paying members at your practice?
Yes. Okay. So yeah, that was the original intent. And so we finally realized, yeah, in 2021, we were right around the winter. We actually really tried to get COVID vaccines early because we said, oh man, everyone should just point the water at the fire. But no, the vaccines all went to like the people who had the huge houses where they could really isolate and work from home and everything. So we realized, oh, we can go back to our plan of actually doing primary care. And so we hired a couple of people, like kind of a front desk person and a nurse-like person who is brilliant and amazing and lovely. And then it was just me and those two. And then we had, so our clinic, we have the foundation side and we have the social purpose corporation side. The social purpose corporation is the clinic. The foundation side is all the other stuff. And we had a little bit of money because of COVID, ironically, and because we were doing everything and we qualified for tons of HRSA funds and different things because we were actually doing a lot of COVID work. And so that allowed us to get started. And then we started building our concierge practice. And that was really hard because I'd always worked with the poor. My homeless patients and my FQ patients were not going to become concierge patients. So we had to win people one by one and just like really convince them that a doctor who's worked with the poor is capable of helping the rich. And ironically, now that I have quite a few concierge patients, I'm realizing, and this is going to sound arrogant, but like it's such a benefit to have doctors who's worked with the poor because they can say like, oh yeah, that is ridiculous. You don't need to do that. I don't know why people do that. The rich get like so much overcare. They'll come in with a headache and they'll get an MRI. And I'm just like, what are you doing? And then they get their incidentalomas and and they're on like way too many meds. And so I'm constantly like backing it up and just saying, hey, this symptom that you have, this is more about your stress than about a brain tumor. And I just am able to reassure them so much. And I have so much experience of really, really severe diseases among the poor that I'm like, no, your abdominal pain is not a gastric cancer. It's just regular old abdominal pain.
And how does that work out with concierge members and people who are not concierge members to give everybody care who needs it?
Yeah. In our clinic, so in the San Jose site, we put them all together and we just have my front desk just schedules them all, and I'll have the lowest income person in San Jose and the highest income person in San Jose back to back in the same office, the same everything. We don't have a full waiting room because I do 30 to 60-minute appointments and I'm almost never behind schedule. And so people aren't just sitting there looking at each other in the waiting room. And we also keep it really nice. We decorate the clinic really well, and it looks like a spa. It's got chandeliers, it's got lots of plants, it's very pretty, and everybody appreciates that. And then I don't know, it just seems like it works. My low income people are not, they're lovely and they're not violent or crazy and I've had a couple patients I've had to let go because they were unable to maintain their levels of respect that they need to have to be in a public place. And because we do put the clinics in the low income neighborhoods, like we've had a couple of concierge people who just refuse to come to the clinic because they're scared to be in that part of town. But most of the time it's fine. And yeah, and we actually think it's really good for the different elements of society to mix with each other. And so many people even have taken it to the next level where they've gotten involved with our foundation side. And, our foundation side, we have people from both the low income and the high income side, because our low income people are just amazing and talented and fabulous. And so both groups come and they cook a meal every Tuesday and every Saturday together. We have a little kitchen in our clinic. and they cook a meal for the homeless, and then they bring it out and they eat it together with the homeless and get to know them with a homeless community that's in our neighborhood. And that's been amazing. So even like some of our low income people who've participated in that have been extremely valuable, because like one of them, he owned it's like a ice cream kiosk at the flea market at the pulga. And he would sell there. It's like a waffles and ice cream kind of thing. And he needed to hire some people. And so he actually hired a couple of the homeless guys, and he was Spanish speaking. They were Spanish speaking. It like worked out great. And he was able to help them to stabilize and get out of their situation. And the concierge patients pay $200 a month. They are, I aim for 300 concierge patients at $200 a month. And then they are paying my rent and they're paying my staff, and they are making it stable. After that, I try to get 600 low-income patients from the neighborhood. We have a very specific geographical area where we'll offer low-income memberships, and they do pay something. So we ask them to pay $150 per year for the whole family, or it's like 70 or 80, I forget, per year for us individual. And so that way they have a little skin in the game. Otherwise, we find them just going all around town to whoever, and they don't have as much no show. And so, yeah, a little skin in the game. And then of course, if they can't pay, it's not a big deal. But we encourage them. We say, just what can you pay? Can you pay $10, $20, like something? And then that way they're connected to us in that way. And then they also are participating, like, because I have my DPC lab fees with Quest, and so I feel very comfortable just doing all their labs and not charging them because they've paid something. And then I just tell them this money just goes towards your care, and it helps us to pay the rent. And they understand that they pay their rent. They understand how it works, and they, for the most part, are extremely respectful and appreciative of that. And they have options. If it's too much, they can go to the FQ.
Absolutely. And let me ask you, in terms of, you mentioned how you have a particular, especially geographic area where you'll offer care. Within that geographic area, do you have some kind of, please fill out this form, or somebody interviewing somebody to try to figure out, even though geographically you're here, do you still meet the qualifications?
We are not that fancy about it, but I would say my people, like my Spanish speaking people, are not paperwork people, and they're not as much kind of spreadsheet people, but they are relational. And within that, it becomes very clear. And my front desk is brilliant and lovely. My nurse is really lovely and amazing. And my community engagement people are amazing and lovely. And they live in the neighborhood. And so like my community engagement director, she is so connected to everybody that she knows everything. So, and then if she doesn't know everything, like one of the madres knows everything. So if someone is giving us a load of BS, we're going to find out.
Yeah, that definitely demonstrates how connected you are with your community to be able to know that. And given the small town feels of places that I have been, like, that is real. It's like someone will speak up about somebody else if something happens, and that could be income, that could be what they did at the grocery store, whatever it is. Like, I totally get that.
You should have seen during COVID, we would try to deliver soup to the COVID positive people's houses, and the people, this is the only place I knew of that we were the testers. We were physically putting the NP swabs. We would bring them soup. We were constantly calling them to see how they're doing. And so we knew who was not staying home. And then we would the people would go and try to knock on the door. And then the neighbors, because these are tiny little apartments with thin walls, the neighbors would peek out and be like, oh, he went to work. And we were so we'd call him up and we'd yell at him and be like, you can't be going to work. But yeah, we just knew everything. And I tried to call, there was 2 families that were really super spreaders. They were just being so bad. One of them was working at a Jack in the Box, and everyone in the family had COVID, and they all went to work at the same Jack in the Box, and people were they didn't have it open, but the drive up was open. And I was so I called up the health department. I'm like, hey, can you they aren't listening to us. Can you just tell them to stay home? And they're like, oh, we don't have time for that. We're too busy contact tracing. And I was like, okay.
I just gave you contact traces that were like legit positive. I ran the test on them. Like, how more like detail do you want in terms of contact tracing? Like,
Yes.
that's crazy.
Yes.
Oh my gosh, those the people, like, when you and I listen to this again 5 years from now, it's gonna be like, it is a little bit already, but it's like, golly, like the world in 2020 was just like, it's something out of a freaking movie with horrific realistic outcomes, but just unbelievable. So now, how about with you having multiple locations? How did you go from we're doing our thing in San Jose to love to bring this care to more people?
Yeah, so a doctor in Sacramento had met us. It was like friend of a friend kind of thing, because he was dreaming of the similar kind of thing. And so he was on our board initially because we were like, oh, you're so aligned with what we're trying to do and you're so perfect. And then he would actually drive to San Jose once a week and just do shifts because he was fluent in Spanish. He's med peds. He's so perfect. And so we loved him. And then but he had this, so again, this felt called by God to like really work with people from the Middle East. And I was like, okay, literally in the Bay Area, we have everybody except a lot of Middle Eastern people. And I'm like, how about the Vietnamese? We've got plenty of those. How about that? No. And so then he had this dream that was something about August 2021 and wait for that. And we were like, what? And then that was when Afghanistan happened. And so everybody who came to America from Afghanistan is like making their way to Sacramento, which is where he lived. And so we were like, oh my goodness, this is perfect. We can create a clinic there to specifically serve the unique needs of the Afghans who come to Sacramento. And so that's what we did. So again, with some of that money that we had gotten from COVID, from all the COVID testing, we were able to purchase an existing clinic in Sacramento that they were kind of ready to retire. And this is the easiest way to do concierge conversion, is to purchase an existing private clinic, and then you don't need all the patients. You just need 300 or whatever, just a small number of them. And so you just say, like, if you want to stay at this clinic, then you're going to need to go concierge. And so immediately they filled, and then we were able to use the proceeds from that to fund our Afghan clinic, which is those are two different clinics. And this one, the concierge clinics in Rockland and the Afghan clinics in Arden Arcade in Sacramento.
Being from Sacramento, born and raised, like, that is so real. I worked with when I was clearing out my dad's house after he had passed. We finally sold his house, and we were like, who wants all of this furniture? Like, I don't want to take it to Goodwill. I'd rather it go to the hands of people who could actually use it. And it was a person who was helping refugees get settled in Sacramento that all of our furniture went to. So it would be so crazy if we had some overlap there. You giving care. Yeah. So that's so crazy. Let me ask you now, in terms of the criticisms that people have for DPC. And a lot of these criticisms come from people who just aren't aware of what we're doing. This is why people like you and I are so passionate about sharing our stories, why I'm so passionate about this podcast. People will have criticisms like DPC is for the rich people, the people who have the funds. DPC cherry picks patients. What do you have to say to those people? Because clearly you've already spoken to the cost factor, but what would you say to those people who are the naysayers or who don't even look into DPC because they believe those things?
Yeah, my experience at DPC, and it's so interesting because as California keeps changing who they cover with Medi-Cal, that's changed a little bit what we do, although we figured out how to accept Medi-Cal. And so with our really weird structure, so we still have the same patients, but the ones, my most favorite patients are the ones who have no insurance. I just love them. And I think it's partly because of who they are. They're the ones who have been striving so hard. They got their own, they own their own house cleaning business or their own landscaping business, and they're not rich. And they're paying sometimes rent twice. I've got a patient who she pays her rent, and she also she has her own salon, and she works her butt off. She's there every day. These small business owners and these mostly immigrants who are just working their tail off and they make too much for Medi-Cal. And I love them because they're trying so hard. They're kind of the American dream, old school strivers, and they get punished. As soon as they cross that line out of Medi-Cal, then it's like, okay, you can pay $800 million a month to go to Kaiser, where you will pay every single time you go there. You're going to like get nickel and dimed and out of everything. And you'll honestly, they just avoid going. Or you can be uninsured and just like have really bad luck and end up in the ER and be financially devastated, or like, there's just not good options for them. And so I love them because I just love being able to support them and keep them healthy. It's also, I mean, it's just fun to have to do a little bit more. So I've got one guy who's schizophrenic, Spanish speaking, house painter, no kids, single man, doesn't qualify for Medi-Cal because you have to make almost nothing to be a single man. And yeah. And so there's no way he's going to see a psychiatrist for like 400 reasons. So it's just me and him figuring it out. And we've had some success. Like, he's doing well. He's still working. He's feeling good. I've got another guy who works in an auto shop and keeps getting metal in his eye, and I keep having to get it out of his eye. And it's like things I wouldn't do in a normal clinic, but you just have to, because you know how much it costs to see an ophthalmologist when you're uninsured. Like, it's crazy. And so I love them. And the people who are in that category are not the rich, for sure. And they really don't have options. They don't have other options. And then among my low income, the Medi-Cal patients, a lot of those guys are like, I've even had Medi-Cal patients who are outside of my catchment area, who we just say, if you're not in this neighborhood, we have to have some kind of boundaries. Like, we can't offer you the low income membership, and you have options like go here, go there. And they've had such bad experiences with the FQHCs that they will try to find, like, they'll ask me if they can just pay the money to see me because they want quality care. They want to get better.
So many examples of that in not only California, but also in places like Georgia. Like, I know I've mentioned this on the podcast, but you have people. I remember Dr. Erin Kiesel, who's been on the podcast before, also at another Robin Hood model in Modesto. She said that a family gathered their funds together to make sure that their grandma, like the matriarch of the family, was able to still continue care with Dr. Kiesel, because they knew they couldn't lose that. Like, she couldn't lose that. And then you have people like Dr. Stephanie Phillips in the poorest area of Georgia, where people are like, absolutely, I'm going to pay you my $75 per month, because there's no way that I'm going without you. There's no way that I'm going to be without a primary care and end up in the ER for all of these little things. So I love that that's been your experience. Thank you so much, Dr. Bymaster, for joining us today.
Thank you.
Thank you for joining us for another episode of My DPC Story, highlighting the physician experience in the world of direct primary care. I hope you found today's conversation insightful and inspiring. If you want to dive deeper into the direct primary care movement, consider joining our My DPC Story Patreon community. Here, you'll have access to exclusive content, including more interview topics and much more. Don't forget to subscribe to My DPC Story on your podcast feed and follow us on social media as well. If you're able, I'd greatly appreciate if you could leave us a review. It helps others to find the podcast. Until next time, stay informed, stay healthy, and keep advocating for DPC. Read more about DPC news on the daily at dpcnews.com. Until next week, this is Maryal Concepcion.